and then at the end we go through your patients, okay? At the end of this moment. Okay. Do you have the slides?
No.
No?
No, I don't see.
No. We see the doctor and Gisela.
Gisela, I see Gisela.
I see
I
both.
don't see my face, and you know I really
Oh, and Veronica.
I
But
see
I'm on
Veronika,
the...
Magda, Beata. Cześć, Justyna.
Hey. But no slide.
Gisela, you can only talk about your patient.
Ja się czuję tak niekomfortowo, bo nie mogę nic zmienić na tym iPadzie. Nie wiem, jaką kamerę. Wy mnie widzicie, ja siebie nie widzę.
Now do you see the slides?
Yes.
Okay, perfect. So we'll go through rebonding. And so I advise you to have a list of what you had to look carefully at the rebonding appointment. And usually you see, I just want to remember why I debond a brackets for a patient. In this panoramic OPG, I just put the movement that I want on my brackets, my new bracket placement. Because a problem with the rebonding is that when you remove a bracket that you bond in the wrong position, most of the time it could happen that you go to bond the brackets on the same positions. So before to bond it, remember very well what is the reason you need to rebond that brackets. Another things that you have to check out, it's to watch out, I'm sorry, to watch out, it's to use the right pliers to make the rebonding, because during the debonding appointment we need to remove the brackets with the more uncomfortable for the patient. In the rebonding appointment, I need to debond the brackets, and I would like to reuse the brackets on the same patient. Because of course, if I need to remove and rebond 10 brackets, at the end of the month, the months are money that goes for my office. So I use these two pliers. Every type of brackets usually has his own pliers for the bonding. These are two pliers that permit us to remove the brackets without deformation of the brackets, of the passive self-ligating brackets and the door of the passive self-ligating brackets. With these other debonding pliers, you see that each time that the point of the pliers are not so thin, and each time that I need to squeeze my plier, I go to deform the brackets. So not use pliers, they go to deform the brackets. And if you think that the brackets is not in the same condition as before, just put a new bracket, of course. These two pliers came from the same factory of the brackets, and so they are from Ormco. And check out before to buy pliers for the debonding, always check out the pliers. Usually, I don't know about what happens in Poland. In Italy, when there is a person or a representative person for a different factory, usually they arrive in the office just with the catalog, not with the model of the pliers. But when you buy a pliers, I suggest you to ask to the representative person that is coming to your office to bring the pliers with him. And so you can have the opportunity to check the pliers and see if they are the right pliers for your use. That's very, very important. Another thing that I stress a lot the colleague during the master in Siena is that I need a paper or whatever you want in which I have to remind the position of the brackets I am debonding and that I have to put in a new bond position. And I found this way, but you can have your own way. This is of course just the cross of the fore area of the mouth, and then for each tooth, this is a central right upper incisors, and there is a problem of occlusal gingival position of the brackets due to the marginal age of the incisors. This is a problem of roots. This is a problem of mesiodistally position placement. And I see on this paper all the teeth that I need to debond. Then before to remove the brackets, I make my last check after that I see that I write down all the brackets I need to debond. So first of all, I go to look at the OPG. Then I go to look to the picture of my patient. Then I go to see the smile line. Then I go to look carefully for each teeth, and in every part of these protocols, I just see on the paper what I think to change. When you have a question mark here, it means that this lower right central incisors has a roots that go mesially, but I'm not so confident to change this position of this incisors, probably because it's not so big inclination. And so it means for me, look at the crown, and if the crown, it's okay, leave it, don't remove and don't rebond these brackets. And I need this chart just in front of me when I start to rebond these brackets. And for each teeth, tooth, before to bond, I want to considerate every reason I'm rebonding it. In this case, I just write down also that I need to talk about the extraction of the third molars. It's the 8 with a question mark to talk with the patient. And of course, when you start to rebond brackets, you need to remove all the composite from the brackets. I use a self-etching machine. Self-etching machine, you can use it directly to the dental chair. Of course, there is a sound blaster machine, so sound blaster, and so sound will goes everywhere on the dental chair. I prefer to have a cab for the micro etcher and in my laboratory area, and so my assistant can clean all the brackets. If you rebond self-ligating brackets, watch out to check the door of your brackets before to bond them. So normally take out all the composite, then use hair on the brackets and check the door of your brackets. If they are still working, you can reuse the brackets. Of course, with the conventional brackets, it's easier because you don't have door and you are not getting problem. Usually I saw that with passive self-ligating, it's not really a big problem. Also with different type of passive self-ligating, not only with them on passive self-ligating. With active or interactive self-ligating, sometimes the door, it's a coil and it gets some problem to close or to open. So use a lot of air on the brackets, and if it doesn't work properly, you need to change the brackets. This is an article that explained that the procedure of reconditioning the brackets in office, it's clinically acceptable. Once again, before to send the brackets to your assistant to clean them, control every bracket that it's not deformed. If you deform a brackets, just change and put a new brackets on. One of the questions that colleague asked about rebonding appointment, it's which arch wire we use after rebonding. Of course, it depends from how big difference are in the brackets position of the patient. If there are small difference, I can reuse the same arch wire I'm using before, normally a 0.184025. Watch out for the nickel titanium arch wire, because sometimes I arrive to rebonding with a 19/425 reverse curve nickel titanium arch wire or nickel titanium arch wire with additional torque of 20 degrees in the frontal area. In that case, 19/425s, if I change a lot of brackets placement, could be too strong, and so I had to go back to a previous arch wire. For this reason, when you finish to use the 14/425 of a patient, instead of trash it away, I usually conserve the arch wire 18/425, and the 18/425 for all the treatment period of my patient, because sometimes it's necessary to go back to that arch wire. This is a girl and the rebonding appointment, picture of the face, and then I start to analyze all the teeth and deciding if I need a different position of these brackets. I saw that this lateral, upper lateral, has a distal placement, so I need to replace these brackets. I need to replace brackets on the premolar. It's a distal placement too. Cuspid, watch out for the problems I explained to you yesterday evening about the cuspid. Usually it's better to have a cuspid placement brackets half millimeter mesial to the normal position, both and these lateral incisors. Of course, I got to see also the position of the roots. You see here that it's not a good position of the same tooth of the upper lateral incisors. And always have the OPG in front of you during the rebonding, also when you have to bond and rebond the brackets you have debonded. Another girl, rebonding time, 18/25, upper and lower, and same analysis about the position of the brackets. You see these brackets rotation. I have metallic ligature under the arch wire. So here I have to stop to change the position of these brackets and leave the brackets without metallic ligature, so permit to rotate this tooth. And rebonding time for this tooth permit us to have a better position of these central incisors and don't arrive to the end of our treatment at the very end of the treatment with the TMA arch wire and start to bend the arch wire to have a different position of this tooth. This is another problem with this lateral lower incisors. Again,
And doctor,
yeah.
Do you stay on the same arch after the rebonding? That, for example, the 18/25?
Gisela, it's up to how big difference are you doing during the rebonding. If it's possible, I stay on the same arch wire most of the time. Sometimes it's impossible to stay on the same arch wire and you have to go back to a previous arch wire. Of course, if I go back to a 14/25 arch wire, I just stay on this arch wire, this old arch wire, just 4 weeks, and then I go through 18/25 for another 3-4 weeks, and then I go to the third phase of our treatment. It's up of how big is the difference in the new position of your brackets.
Okay.
Here again, I change the value of torque on the cuspid of this. Sometimes this happens quite often that you arrive at the rebonding and you realize that cuspid don't have the right torque that you can achieve. And so that's the right time to change the value of torque, because of course, when you are working with torque, you know that torque is something that the brackets and the tooth receive gradually. It's not something like a band of first degree that it could be change the position of a tooth in 1 month. Torque needs 2, 3, 4 months to express all his information. Lateral incisor. Lateral incisors, upper incisors here. At the rebonding time, I didn't realize I had to change the position of these brackets. I had to go medially. And you see here, I got through a stainless steel, still having the same bad position of these brackets, of these lateral incisors. And then I go to TMA. And then I start to have some modification. I put a Steiner coil on central incisors, and sometimes it could happen that you see here I arrive until here, still having a little rotation of the lateral incisors. Of course, I go through retainer period with S6 appliance, removable appliance, and so with S6 appliance I can have a little bit activation to change the rotation of this tooth. And like this one, you can have a lot of mistake that we usually don't see in our patient. Don't see with our patient because also during rebonding time, it was me that do the rebonding appointment in my office, and I took all the time that it's necessary, 1 hour, but sometimes you don't see the mistake right in time. And for this reason, sometimes I go through what I call mini rebonding. I mean, when you realize that there is something wrong in the placement of your brackets, you can realize it in every single appointment of your patient. There are some appointments in which you can stop and say, okay, I got to deband this bracket and I put a new placement for these brackets on. Other time, I'm sorry, I have to check okay, no, because Dark asked me to record the session. Other times, I can't have enough time to rebond the brackets in the right position, and so in that case I'm just taking a new appointment for the patient with enough time to do the new position, to have the bracket in a new better position. Remember that you can do this kind of mini rebonding in all the phase, but I don't advise you to do mini rebonding on the third phase, because during the third phase, if you change something on brackets, it's very, very hard to insert the stainless steel 19-425 on the in the slot of the brackets. And for this reason, when I see something wrong in the placement of my bracket patient brackets, I prefer to see on the dental chart and of the patient, and before the fourth phase, I got to make the variation. Another thing that I realized that, of course, when you work as an orthodontist, you have to know how to bend the arch wire. It's not like 20, 30, 40 years ago, in which we had to bend all the arch wire of our patient. I remember the time in which I was all day bending arch wire, because of course when you start to bend an arch wire, you have to report the bend most of the time in the new arch wire. So the check of a patient with fixed appliance, it takes a lot of time. Straight wire techniques permit us to bend less and less. And it means that at the final phase of our treatment, we have to know how to bend an arch wire, but we have to consider that sometimes it could be easier to change the position or the value of a bracket instead of add information on the arch wire. So it's up to you, but there is no technique, fixed technique, in which you can't bend never an arch wire. So when you have the opportunity, take practical seminars about to bend the arch wire. Go to the treat foundation. It doesn't care if you are not using treat technique, but it's necessary to feel comfortable in bending arch wire. In this case, slide is coming, okay. This is a girl, she's a mouth breather. She has a first phase orthopedic phase with a couple of palatal expander, and we arrived at the permanent dentition in this way. You see, there is after a couple of palatal expander, there is still a narrow palatal form of this patient. I feel comfortable in this case to use directly fixed appliance instead to go through another palatal expansion. You see here on the left side that we have bone, so it's possible to have a vestibularization of these premolars, or also the other side of the first premolars. And it's not very big crowding on the lower arch. We have a shape, a particular shape on the second right premolars. It's a long face. You see here the cephalogram, and this is the panoramic OPG. And of course, we have to reconsider the extraction of the lower third molars. Okay, I go through the protocols. So in this case, I just start with 0.14 upper and lower. I put high torque on the upper cuspid because it's very, very high, this cuspid on the left side, and I know that when I put it down, I go to lose torque, and so I need more torque on this tooth. And I choose also to have a extra torque for the first lower bicuspid left side. I'll go through second round arch wire. You see that the second premolars of the left hand side, it's has the same different shape of the right hand side. Probably it's a little bit smaller. In this case, you have to reconsider if you make a turbo stripping and to reduce mesiodistally the shape of the crown of these premolars. Then I go through the second phase. In the second phase, you know that the first arch wire of the second phase is always 0.14 for 0.25 upper and lower. And in this phase, I want to create a block from cuspid to cuspid. So I have some diastema on the upper arch, and so I put a elastic chain on the upper frontal area from cuspid to cuspid. It's always a elastic chain with space. I don't need to close space as you see on the lower arch. And I added at this point, I added a elastic, triangle elastic, early elastic to just to stay in the right position of the cuspid. So they are triangle elastic from upper cuspid to lower first bicuspid to lower cuspid. And the force of this elastic are 4.5 ounce, not more than 4.5 ounce. Then I go through just the second arch wire rectangular copper nitride. It's as you know, it's 18 for 25. and then I put metallic ligature on the two upper cuspid. Then it was the time for rebonding time. You see here the panoramic X-ray, just considering the position of the roots. Then I got to consider the position of the brackets. I need to have a new position for this upper lateral incisor, right hand side. I'm moving these other premolars. And then I went to the third phase with stainless steel. Of course, I need to close some space between cuspid and bicuspid. I have stainless steel, upper and lower, and I put a little P on the upper arch, and I start using elastics, strong elastics for the Demon technique. It means 6-ounce elastics from first molar to first lower molar to hooks on the arch wire. And in the different appointment, I change the position of the elastics, and I go to tent elastics. It's the same elastic, same force, 6-ounce, but it is an elastic from first bicuspid, lower bicuspid. Then the two parts of the elastics goes to the upper cuspid, to the hooks on the upper cuspid, and then go back on the lower cuspid. It's a kind of elastic that permit us to have a better intercuspidation of the cuspid area. Of course, I used the tie back on the upper arch to close the space between cuspid and bicuspid, both sides. And this is tie back first and second area of the upper arch. Then I'll go through my fourth phase, TMA phase, and in this case I still have some space on the upper arch, and so I put an elastic chain. When I use the elastic chain in the last phase of line treatment, I need an elastic chain with no space. And of course, using elastic chain on the upper arch, I can choose between two different types of TMA. You know, I explained to you about the use of TMA low friction and TMA with the purple TMA. Purple TMA has a friction coefficient between TMA, the normal TMA, and stainless steel. So because I need to close as much as possible all the space on the upper arch, in this case, I prefer to have a purple TMA on the upper arch and a normal TMA on the lower arch. And I still use elastics, in this case are triangle elastics, to have a better intercuspidation on the lateral area. On the fourth phase, I just changed the position of some brackets, and so I have done what I call a mini rebonding, and I would like to have a low torque on the central right incisors, and so I changed the bracket and put low torque instead of add a Warren coil, or I can add add negative torque on the arch wire in the first upper right incisor area. I changed also the position of the second lateral of the lateral upper right incisors, and change also the position of the brackets on the cuspid, just to perfectionate the position of the tip of the upper right left cuspid. Die. Okay. You see here, during the fourth phase, go through metallic ligature on the upper arch, start working with triangle elastics and box elastics to have a triangle on the right and box on the left side. And with the box elastics, I involved 4 teeth instead of 3. I put a wedge on the central incisors. You see here the difference of the value of the bracket torque on the central right upper incisors, but I need to have some extra rotation, and so I put the wedge. When you put a wedge, of course, you have to consider the possibility to remove the metallic ligature, because it will go to block the wedge effect on the on the tooth. And then we arrive to the bonding appointment. This is the face of the patient, and these are the teeth of the patient. So in this case, I prefer to change the value of torque of a bracket instead of put a Warren or add negative torque on that tooth. Why I've done in this way? Because the patient came very far from my office, and so it wasn't possible for me to see her in the last phase very often. Okay, there are questions about torquing or about rebonding. So we can go through your cases now. Who will start? Gisela? Do you start?
Yes, okay, I can start, but doctor, you have to show my email.
Yeah.
Could you, because
okay. Okay, Gisela, do you see the slide?
yes, I see it.
Okay.
I have also my telephone open this presentation.
Okay, for everyone, we discuss about these cases. Every one of you want to have a any idea, just open the microphone and speaks, please. And it means also any idea with different technique, with different appliance, of course, because it's not just that we have to talk about fixed passive self-ligating, but whatever you consider on this Gisela patient. So go ahead, Gisela.
Okay, give me a second. This is my patient. She's 34, she's a young woman, and she has a short face, rectangular face, straight profile, and a really deep bite, and also I see the abrasion on the lower incisors. She has also a second class retrusion of the upper incisors and protrusion of lower incisors, and the narrow upper and the lower arch, and the crowding. And in my, yes, can we see maybe the next slide, Doctor? Oh,
Okay.
and here we
Before
see
this,
a severe
yeah,
crowd.
Gisela.
Yes.
Before this, can I ask you why this girl came in your office? What she wants? What she feel uncomfortable in her face or in her teeth? What is the problem for her?
For her was the problem with the breathing the teeth, yes, because she feel uncomfortable because she see that her lower teeth, lower incisors are started abrasion, yes, and the I think that the male doctor said also that it is the problem with the abrasion, and suggested to go to the orthodontics. And also she wasn't satisfied of her smile, because it's not looks I don't know how to say, imagine. Maybe she wanted to change something, because her smile is flat and not enough exposure during the smile, yes.
Okay.
And when I take the photo and make a scan for the virtual models,
Okay.
I show her this everything, and she agree with me that yes, it is the problem with this deep bite, and she doesn't see her lower teeth when she smile, when she bite, and also this problem with the really big retrusion of the upper incisors.
Protrusion of the upper incisors.
Yes.
Okay. Yeah. For me, that's the first things that I want to know about the patient. Why the patient is in my office? Because sometimes you discover that patients see very different problems for our orthodontic idea. And that's very important to see on the chart of the patient, because you have to know exactly the reason why your patient came in your office. Because at the end of the treatment, patient thinks that you got to resolve the problem that brings the patient in your office. So for me, that's very important, because sometimes when you see this kind of conclusion, patient arrive in your office and say that he has some headache or neck ache problems, and they think that with the appliance, with the treatment, they got to say goodbye to all this problem. Of course, with this bruxism, with this problem of clinching during the night, you know that at the end of your treatment, of course, changing the position of the teeth can help and reduce the clinching effect on the mouth of the patient, but probably she needs to wear a bite after your orthodontic treatment. Instead, it's you can do probably a lot for the upper incisors retrusion. Okay, there is any question? Yeah.
I also ask my patient. My first ask in my dental office is what to suggest you to come to me, and of course, mostly my patients are smiling and they are surprised. Why I ask them about this? Because they came to the orthodontics, yes. So they want to strike the teeth, and it is the normal. They want to appliance only like this. But I explained them that I ask about the profile, about some asymmetric, because in this way I can't help only with the orthodontic treatment, but we have to use also the surgery, yes. And then this patient said what I mean about this. And when I show the photo on the treatment plan visit, they know on which factors we can focus in the orthodontic treatments, and we can help with this, and on which it is impossible without the surgery, for example.
Yeah, that's true. That's correct.
So I explained this woman that this short face, this profile, it will be mostly the same after only the orthodontic treatments. But she have also a deep bite, yes. So if she wants to change something in her face, so it should be necessary also the surgery.
Perfect. We'll go through the cephalometric analysis, if it's okay for you.
Yes. And we see that the value of the upper incisors is too low. Yes, it is 96 degree. And on the lower incisors is 100.5. So it's they are too much protruded, and the incisor angulus it's 143 between the upper and the lower incisors. And I decided with the patient to use the diamond brackets system.
Okay, wait. Okay, before to treat before diamond brackets or whatever. So patient needs what?
Patient needs what? A patient needs to create more expander. I hope that I say this correct in English. More expander upper and lower arch. Correct the crowding in the lower arch. Correct the deep bite. So intrusion the upper incisors and the cuspids, and extrusion of posterior teeth.
Okay.
And the second class elastics to correct the second class.
And we have also a very dangerous broad deposition of the premolars.
Yes, it's no crossbite, but relapse. I don't know. In Polish, it's gryz przewieszony. I don't know how it's in the English. I'm sorry.
That doesn't matter.
Brody bite.
Yeah.
Brody.
Brody.
Brody
Okay.
bite.
Brody. Yeah, it's the same in Italian. It's Brody.
Paulina.
Yeah. Okay. And so you decide to use differential torque for this patient.
And I hope that it is correct.
No, that's because, of course, in this patient, if we go back to the frontal view, you have to imagine to change the proclination of the upper incisors, and remember the flaring effect on the upper incisors. So I don't want to have a flaring effect on this face to change the upper incisors vestibularization too much to having a flaring effect on that teeth. But as corrected what you said, we want an exclusion of the posterior area of the patient because it's a very brachyfacial. It's and we still want to see the upper incisors crown. We don't want it that you go to disappear the upper incisors crown in this patient. The other things is that we don't have the lateral sonograms. Sorry.
Yes. I'm sorry, I forgot about the OPG because my assistant, she prepared me this photo and I forgot because now I'm focused on the master thesis and
no problem, Gisela. But you give us the cephalometric value, and so it's possible to change the position of the upper incisors because they are retroclinated, and so you have to first of all think about what should be the mechanic as you told before, and then you need to go through the single teeth, upper incisors, single upper incisor teeth, lower incisors teeth, cuspid teeth, bicuspid, and see how much it will be the expansion necessary, because fortunately it's not, you don't need a big expansion in this case. So a dental modification probably for the transversal point of view, it could be enough. The only problem is to check the first bicuspid on the lower arch. You see that the first bicuspid is quite out of the alveolar bone.
Yes.
And the lower incisors are area. I'm not afraid about this second, the first bicuspid in a Brody position, because it's probably he arrives with few space and it went lingually and create the Brody position of the teeth. So we go through treatment plan with the value of torque, and explain me about the value of torque, Gisela. Explain us.
Because this patient have a retrusion of the upper incisors and a deep bite, and I will be also use the second class elastic. So I decided to put the high torque on the central incisors, and I wasn't really sure about the lateral. I wonder about the standard and the high torque, and I really don't know what the doctor suggested. And I think that I should put in this case also the high torque on the upper canine to create more expander arch on the upper. And on the lower incisors, I put the low torque because in this case, I have a more protrusion in the lower incisors, and I will be also use the second class elastic. So I decided on the low torque. And the lower canine, I decided about the high torque to create a more space in the lower arch, and lower left first premolar. I wonder about the high torque. And now when I see this photo again, of course, the right premolars, it should be on the standard torque.
Okay, some consideration to do together. First consideration, on the lateral cephalograms, we would like to see how is it the situation of the mandible. Is it a small mandible? Is it a retruded mandible? Because of course, every time that you see a deep bite, you have to imagine there is something, there is a wall against the mandible that creates a stop in the mandible that can move forward. So it's an adult, and on the lateral cephalograms, we would like to see how is it the situation of the mandible. In a lot of cases like this one, we have a retruded normal mandible. It means that also if it's an adult, creating a modification on the frontal wall of this mouth, you'll permit to the mandible to move forward. And the other things, looking at this picture, is the situation on the lateral incisors. Every time that you see lateral incisor, consider if, and you have to use high torque, what will create? Will create a wider arch. Low torque will create a narrow arch. So if I don't see any space on the upper arch, I have to ask about are lateral incisors the right side or they are smaller? So Gisela, I suggest you to measure them and see if they are smaller. Go to see the Bolton and see if they are smaller or they are the right size. Then if they are the right side, probably, as you told, I'm not putting extra torque value on the lateral incisors, because if you see this occlusal view, they seem to have more torque on instead of the central incisors.
Yes.
So it's correct what you are talking, what you explained, to have a differential torque between central and lateral incisors. Of course, talking about the lower incisor and choosing torque, we have to, we would like to see better the parodontal situation of these lower incisors, and in the deep bite, it's not easy to see the situation. It seems, in this picture, it seems that the right side is better than the left side. You see,
Yes.
the midline, it's okay, it's quite okay, but left side, it could be a little bit different. And if I go to the occlusal view, it's the occlusal view, there isn't difference in occlusal view from position of the incisors. So probably don't need too much low torque value, like -6. And cuspid, I agree with you about the cuspids, because on the upper arch cuspid, look at the right side cuspid, it's very palatal version of the crown of the cuspid, a little bit less on the left, but it's correct to unlock the upper arch, the cuspid area, and it will permit to have a better effect of the mandible to move forward, and that's the same reason we think that in the lower arch we need to create some space, and so it's necessary to have a better to conserve the gingival area of the cuspid, the lower cuspid, as much as possible. So it's correct to have a high torque on this cuspid and the high torque on the first bicuspid. In my mind, when you start working in this case with build-ups,
Yes.
you see a very important movement of the mandible going forward. On the way you are changing the vestibular, the upper incisor position. And the only thing is that you have to consider if it's necessary to have a coil on the lower arch on the first bicuspid area. In that area, you have to consider or to make a little bit of stripping or to use a coil. And using a coil, of course, you'll get more effect on the cuspid to control. But probably you'll get some space. On the other side, if you look at the second molar, first molar, when you go to put braces on first and second molar, second molar and first molar will have some space here. There is a rotation on the first molar. So probably in this case, I will start at the beginning with no stripping, and I will consider to make some stripping is necessary during the treatment. And what about build-ups, Gisela? Where do you think to put build-ups in this case? It's a brachyfacial, so it's not necessary to be afraid about the second molars, isn't it?
Yes. So I decided to put the builds up under the central incisors.
Under the central
in the anterior area. It is correct.
Yeah, okay. You are talking about to use build-ups on the central upper incisors, isn't it?
Yes. Okay. Yes.
Of course, you have to consider that on the way you are changing the position of the upper incisors, you have to check build-ups, because the build-ups has to touch on the lower incisors. Patients don't have to stay behind the build-ups. If it happens, you can consider to use a longer build-ups for anterior area, as I showed you yesterday with the tiger mold, or you can consider to use build-ups on the halfway area, bicuspid or cuspid.
Like something like these twin blocks, yes? These cases.
Yeah, but if you are using build-ups on the halfway area, remember they don't have to block the movement of the lower arch. That's very, very important. Because if I use build-ups on the halfway, I would like that with the first phase and the beginning of the second phase, that the arch wire can work as easy as possible. Other things, when you see this kind of crowding on the lower arch, and this is an adult, works with the right time with the arch wire. That's very, very important. The first arch wire stay 10 weeks and leave the 014, 016, 018 to work as much as possible. 014, 425, the same. Don't be in a hurry to arrive to stronger arch wire. That's correct. And sometimes, sorry?
I'm sorry, I have, because in the upper, the central incisors and the canine, it's correct to use the high torque, but in the lower arch, you suggested to not to use the high torque on the incisors, yes? But I'm afraid, about this value of protrusion of the lower incisors, and also maybe adding the class 2 elastic. It's
No, Gisela. No, I'm not saying that you don't use low torque on the lower incisors, but I'm just considering to use a -6 low torque value instead of -11. I mean, it's
no. This the extra low torque, but the normal low torque.
Yeah, and it's up to the situation, gingival situation, and also of the bone of the symphysis.
Okay.
Okay, watch out on the lateral cephalograms about the bone of the symphysis, about how much bone there is in that area.
Okay, doctor,
Okay.
thank you.
And we have to consider to using early elastics or not in this case. But at the beginning, I don't want to use early elastics until you don't go to open the bite completely.
Okay.
Okay, so work and arrive to the main mechanics probably before to use elastics.
Thank you.
And what else? I don't think anything else. There is someone who wants to say something.
And this, I'm sorry, this left first premolars. It is correct to put the high torque or not?
Yeah, absolutely.
Okay.
Absolutely, because it helps you to move it as fast as possible and to go away from the Brody position. Probably this Brody position here, and probably this picture.
I think that here it is the mirror.
Okay. Yeah, perfect. Yeah. This one.
Here,
Okay.
yeah.
No. So the Brody is on the right side. Yeah, it is the mirror, and the Brody is on the right side. Yeah. Okay. Did I give you the chart about the torque? I like this one with the paper on the torque. Yeah. Through direct or not? No, because
no.
Usually when I work with differential torque, I have always in my pocket a small paper in which there is like a small, because it's so big, and in which I write down all the value of the torque that I use in my office, because every time that you see the patient, you can consider about the value you are using on differential fit. And as I told you about the torque, the possibility to have differential torque, not only low, high, and and standard, but also differential torque. I'll send you through direct these sheets. Okay.
Okay.
We'll go your second one.
Okay.
Julia, isn't it? The name was Julia, the second one, yeah.
Yes, yes, Julia Stempin.
Okay. Do you have a slide?
I sent this email twice because on the first time we didn't see the other.
Yeah.
I also tried to open my computer, but I'm sorry, it's she is a young girl. She's 13, and her profile is retrusive. She is in second class, and with the deep bite, and the second class with the narrow upper arch and retrusion on upper incisors, and a little bit of crowding on the lower arch.
And what about the face, Gisela? I mean, don't know if it seems that the midline, it's not, there is something on the midline. I can't understand if it's the nose that goes on left.
Yes, she has a little bit of asymmetric on the right side, but in the midline in the teeth, there looks correct.
Yeah, the midline in the teeth looks correct, and looks correct also if I take a look of the face and I look only the third part, the inferior part of the face, it looks correct, but it seems like the nose goes on left. Just check it.
Maybe a little.
Yeah, just check it, and if it's in this way, just explain to the patient that there is this asymmetric position, probably due to the nose, because sometimes patients go to have this kind of feeling at the end of the treatment. So try to understand better the midline of the face of the patient. Okay, yeah. It's a beer intrusion, you told. There is a midline, upper and lower midline are correct.
And she has a narrow upper arch, and a little bit of crowding in the lower arch, and also it is a little of narrow. And the value of the upper incisors is too much retrusive. The value of lower incisor also is too much retrusive. And the value between the upper and lower incisors, it means that we have a bilateral retrusive. And in this patient, the problem which I have to solve is expand the upper arch, correct the retrusion of incisors and the deep bite, of the incisors?
Gisela, always don't talk about expansion of the arch, but with fixed appliance, and in particular, don't talk about the expansion of arches during the thesis, because it's not correct. I mean, we have expansion in a young
When we the hyrax, for example,
yeah,
yes?
yes, or with surgery or with IREX. With fixed appliance, we can reconstruct, we can
Yes,
create a vestibularization.
more space, yes.
Yeah, that's important to use, particular during the thesis, all of you, some words that are not misunderstanding, because of course, if in the thesis there is Pietro Nanelli, from which I learned all the use of IRAX that I know, and you say to him, we need to expand this patient with fixed
Yes.
Of course, he spent all his professional life to put the emphasis about difference about palatal orthopedic expansion versus dental reconstruction. And so pay attention to use on the thesis the right words.
Yes,
So
yes. So
here,
correct.
the palatal,
Yes.
yeah, palatal in this patient, it's yeah, it's a bit crowding on the upper, like in the lower arch, but palatal, like talking about the bone, it seems quite correct in this patient. Okay, and it's not a particular problem case, this one, in my mind. It's not it's not a difficult case. And what you suggest about the torque value, okay, let's talk about
I
it.
suggested about high torque in the upper incisors and canine, but I think that doctor said that maybe it should be standard, unfortunately.
No. Go ahead.
And
Remember, no, Gisela and all of you, when we are talking about differential torque, also in different brackets technique, it doesn't mean that the rule is that if you say central and lateral high torque, and I say no, the standard for me, it means that you are perfectly correct or I am perfectly correct. But it's it's necessary to try to look at the problem. So if I need to create an overjet here to solve the second class malocclusion, I need to change the torque value in the frontal area or the torque value in the lower area of the incisors, or both. If I need a mechanic with a lot of second class elastics, it's the way you are thinking about that.
yes, because
It's important for me. Okay,
yes, she
it's like, yeah, it's like when you make a cephalometric analysis and there is an instructor say, for me, the Bayesian point, it's in this position, and for me, it's 3 millimeter in this other position. But it's why it's important, Bayesian point. It's important for this value, and then it's the way you're thinking. So just
for me,
follow your mind. Don't worry, follow your mind.
Why I decided about the high torque in the upper incisors, because this patient has this narrow arch, has a deep bite, retrusion, a little bit of crowding, and the second class. And I will be used the second class elastic. And I think because when I observe the patient like this, especially that she will be still growing. And very often I see the patient during the treatment, during the growing, that for example, the maxilla is growing and the mandibular is stopped. So I think that during this treatment I will be use a lot of second class elastic. So in this way I decided about the high torque in the upper incisors. On the lower incisors I decided about standard torque despite the second class elastic, because I also want to create a more wider arch, and now in the position of the lower incisors is too much retrusive. So I decided about the standard, but on the canine and the first premolar, to create the wider arch and help with the open the bite, I decided about the high torque. It is my, I don't know, opinion, and I want to hear about your opinion, doctor.
That's correct. That's the way you have to think about. You suggest us that you feel comfortable with a difference of torque between second class torque, with a difference that means I will prefer high torque on the just on the upper and not low torque on the lower incisors. There is a difference. That's fine. We go back to the other picture. Okay. Incisors. Lateral incisors. You see the difference? That
yes,
are in a good shape. There are not small incisors. There are normal incisors on the upper and the lower instead of the other patient. And probably we need the same amount of torque on the 4 incisors. And as you told you, but of course we need to have a look of the symphysis. Always take a look on the symphysis of the lateral cephalograms to see what's going on the lower incisor, choosing the right torque. If I see the lateral picture, yeah, it's a second class, but I don't know if you really need a large amount of elastics in this case, Gisela. Probably just working with the arch wire, you get a movement, and probably it's not necessary so much elastics.
Okay.
And so it means that if we start with a value of torque of second class, we have to be ready to change the value of torque if you think that will be too much torque on the 4 incisors.
Okay.
So take a look about the
face.
Yeah, about the face, about the flaring of the upper incisors. Each time that you are using high torque on the frontal incisors, first things that you have to look to your patient when she came in the office, it's the right amount of torque, what I'm using, or I am creating a flaring effect on the smile line. Flaring effect, it's a collateral problem that I can create on using high torque on the upper incisors. So if in this case, in the middle of the treatment, you realize that you don't need too much use of elastics or second-class elastics, just think about and say, okay, I don't need too much elastics. What can I do? I can change the value of torque of the frontal incisors, or I can reduce the arch wire I'm using. So I can go from 1925 to 16 to 25. And I will reduce the amount of torque that I'm using. So it's up to you.
So, doctor, for example, the standard torque on the upper incisors, it will be okay. And what about the cuspids? Because I wonder.
Gisela, wait. It means that you feel comfortable using high torque in this case. Try them, but okay, write it down, and at the rebonding appointment, during the main phase, during the beginning of the last phase, just reconsider that you are using that kind of value of torque on the upper incisors. It will be okay, perfect. If it's too much, always remember that in each technique, we are talking about just a number of value of torque. It doesn't mean anything to me if Roth is using a value, Ricketts is using a value, Giannelli and Tweed using.
No.
It's a number. So what I have to think is, if it's too much, I have to change something. And that's
for me it is also the learning. Yes, these cases, it is the learning, and I try to understand this the differences about the torque, and which this my choosing of torque is correctly or not. I know that sometimes it's really difficult to say yes, high is okay or not. But for example, I understand here the standard and the high should be okay, but I have to be careful about the flaring effect. But for example, I wonder about the cuspids in the upper and in the lower, because the cuspid in the lower, now the gingiva, it looks okay, but I wonder that when I use the high torque brackets in this place, it will be a better position of the gingiva.
Yeah, I think that high torque on the cuspid, it's necessary to use. I would not start this patient with a standard value of cuspid. I prefer to have a high value of cuspid on the lower, and also on the upper. Of course, you see the gingiva, you see the area of the roots of the cuspid, of the upper cuspid. It seems that high torque could be a right choosing the right value, but I'm sure about the low torque, the low cuspid. Just watch out if upper value of torque, it could be too much, because you need to have a good intercuspidation of the upper cuspid. But you see this when you arrive at 1825. And when you arrive to 1825 and you have a good alignment, what you have to do is to try to move the mandible in the right position with a good intercuspidation of teeth. And at that point, you have to imagine to use not 18 for 25, but 19 for 25, that it's the higher arch wire that we are using with passive self-ligating. And at that point, you see if it's too much high torque or not. Okay, Gisela? And on the lower first bicuspid, On the lower first bicuspid, I will use a standard torque. I don't see big difference to use a high torque value for the first bicuspid, lower bicuspid, Gisela. And what's again about build-ups?
Okay. And the build-ups, I also wonder, like the previous patient, about the anterior build-ups behind the upper central incisors.
Yeah, that's correct. But in this kind of patient, you can have also build-ups on posterior areas sincerely, and just looking what's up. And I don't think that this kind of patient, it will create a big intrusion effect. And so you can start with build-ups where you feel comfortable and just check them during the treatment, but it's not like the other treatment. When you see that kind of deep bite, it's completely different from this one. You see in this frontal picture, you see a little bit of the lower incisors. Here,
yes, it is. It's really difficult. Different cases like this, the previous. Yes.
Yeah, in the previous, if I got to use build-ups on the posterior area, I will get intrusion of that teeth. I don't think that in this case you got to get a lot of intrusion. Of course, after a while you practice build-ups, you start feel comfortable about this, because every time it's like the elastics build-ups. Every time you are using build-ups, I have to look when I see the patient for the check. I need to think about what is the collateral effect of my build-ups. Intrusion, I got to see if there is an intrusion. Mandible that shift lateral, that go backward, I got to see if there is that effect. There is that effect after 4, 5, 6 weeks. Just change the build-ups, remove the build-ups, create new build-ups. So it's the same, but I don't think there is big problem in this case. Whatever. Okay. Yeah, that's good. Yeah, that's good. So who is next? Veronica?
Veronica, jesteś?
Yeah, Veronica.
Sorry, because I turned off the microphone. I have to try to share the screen. And it's working?
Not yet.
No.
Yeah.
And now, yes?
Yeah, we see the patient.
Yes.
Yes, I have to go to the up of my presentation. This is the patient, 15 years old, is David. He came to me, is the smile, with her mother. She complained about the diastema and a little bit of crowding of the upper arch. But the most problem which I saw in this patient is the retained canine, and he has the milk tooth too. On the front view has a deep bite. There are a little bit of mesial rotation of first incisor, little bit of mesial rotation of second right incisor, and lingual position of the second upper incisor. He is retrognatic. He is class 2. has retrusion of the upper and lower incisors. And in the lower arch, he has a space. And it's a little bit difficult case for me, not so easy. And in the
wait. Lateral cephalograms. Let me see. Okay.
Is retrusion. Yes, and the
okay.
The
cephalometric analysis. You show cephalometric. Okay.
And its SNA and SNB is decreased, and is retrusion of lower and upper incisor, class 2. And the canine is on the palatal side.
Yeah. Does he extracted the
I
third
didn't know that there is the canine because he came to me with aesthetic problem, and mother and he didn't know that they have milk tooth, and they didn't know that there is the permanent tooth on the palatal side.
Okay, before the torque selection, let me see the panoramic OPG again. On the second upper molar, on the right hand side, there is a problem. It's an effect. Go on the OPG. No, on the OPG. Panoramic. Okay, there is a something on the second upper right molar.
Second upper right.
You see in the crown. What is it's a X-ray effect, or it's a problem of the teeth of the tooth? You see that area, gray area?
Yes, I see.
Yeah, just check it.
Yes, I'm not pretty sure it says effect of X-ray. Maybe I have to make only one teeth X-ray.
Yeah, perfect. Okay, and then go ahead before to talk about the torque, Veronica. What is the problem in this patient? We have a problem of cuspid, ectopic cuspid.
Yes, deep bite, class 2.
Deep bite, class 2.
Class 2 retrusion of the upper and lower incisors.
Perfect. Go back to the lateral cephalograms. Because this is a second class of one tooth for each side. You see here the second class molar relationship.
Yes.
And it seems that mandible, it's not a very a small mandible, but incisors, upper lower incisor are very retruded.
Yes.
So we were talking about, of course, but I would like to change the position of the upper incisors and permit to the mandible to come forward. But we have a second class of one teeth, and so the first things that I have to think it's 15 years old. I go through an herbs appliance, question mark. It could be herbs appliance needs to have an extra overjet in the frontal teeth, and there is also a problem of ectopic cuspid.
Yeah.
So to use a nerves appliance for the second class, I have to create the overjet. Yeah, I have to put the cuspid in the right position before to start with the herpes appliance. The other things that I have to think about is I'll do through fixed mechanics, just fixed mechanics, but it's a long way of second class because it's the molar, it's in a very second class position. So probably I have to think about a huge amount of cooperation with second class elastics, or to use auxiliary appliance like forces, like power scope. Sorry, Veronica?
I think about power scope.
Or about power scope, because we have a long way. Okay, after, yeah, there is someone? No. So after this, what you are, if we start with fixed appliance, what do you think about? Go to the
torque?
Yeah, to the torque selection.
And I'm not pretty sure, but I think to put low torque on the left incisor, because of I put the coil to open the space for the Ethiopic canine.
Yeah.
For the when I remove the Ethiopic canine, when I remove the milk tooth, if the tooth will be so in the good position to put the brace, I think to put the lower torque, or first the button to little move to the stick. On the front incisor, I think to use high torque.
Mm-hmm.
And the left incisor too. And the rest, I think about standard torque.
Okay. So, yeah, I agree with you about the difference of torque in the frontal upper area, because the lateral incisors has more torque than the other three incisors. And then considering that probably I need a coil here to open the space for the cuspid, for the permanent cuspid, these lateral incisors will receive extra added torque from the open coil. And so I agree to use standard one on the lateral upper incisor, right upper incisors. Probably on the, oh, sorry, low torque, yeah. Probably, Veronica, this low torque, considering that coil will create more torque on the lateral, but I need torque. You can consider from low to standard torque this, but start with low, that's okay. On the cuspid, probably low torque could be, it's the right way, but it could be still not enough, because probably the roots of this cuspid, it's here in the palatal.
Yes.
So when you bring the cuspid in the right position, if you see that you need more extra negative torque, you need to add torque on the arch wire, or you need a Warren coil, or you need to find some other value of torque, just turning upside down, and to have a very, very low torque value. So remember this, because the value of torque of the cuspid, it's -9, the lowest value of torque with the of what we have on torque value in them. And then can I see the low picture?
In low picture, I'm confused about standard or low torque. I choose the standard because of the space, but I'm not pretty sure.
Yeah, we have a little bit space, but be careful. You need a lot of second-class elastics or forces or power scope.
They need low torque.
That means that you what you are afraid in this case it is to have a proclination of the lower incisors.
Yes.
So if the symphysis go to the lateral cephalograms, we go to see the symphysis. Yeah, we have a good symphysis. So you can consider to use a -11 of torque or -6, and then to reconsider the value of torque at the end of the second class correction. Because using a forces or using a power scope, you have a proclination of the frontal area of the lower incisors. So I will use a low torque value. And in this case, don't use early elastics, Veronica.
Okay, because I don't have a canny.
Yeah, and you don't have any overjet in this case, so you have to create overjet. You have to permit to the mandible to have space to come forward, and when you have the overjet, at that point you need to decide to if you go directly to power scope or forceps or other advanced system auxiliary, or to go through elastics.
I think, doctor, about the bonded first the upper arch and then after came the canny the lower.
Yeah, that's a good idea. That's a good idea to have also to bond the two arches in different time, but you see that will be no many months, because when you start to opening the space for the canine, when you extract the deciduous canine, in very few months you get the permanent canine in the right position. Okay.
Okay.
Of course, the space in this case, the space between the teeth are not a big problem in this patient. What's about the build-ups, Veronica?
As I think about it, I think about it and the front area, but I'm confused is because I need to have a big build-up because of the ectopic canny in the crossbite.
Yeah,
and true. I think about injury of the first teeth. It could maybe it's better to put it in the back.
In this case, the ectopic canine that is growing and it will go lingually in a lingually position. You need build-ups as high as
Yes.
to solve as soon as possible the cross-bite position of the canine. So you need build-ups at the beginning for the canine, and then probably it's better to change the position of the build-ups and reduce the higher of the build-ups, Veronica?
Yes.
Okay, and I told you I will start probably with power scope with forceps in this case. When you are with stainless steel, of course, not
Yes.
before, like protocols, and when you are stainless steel on upper and lower arches.
Yes.
Okay, good. Inga. Inga is with us. Inga. I don't see Inga. Paulina.
Yes.
Send me a couple of
Yes.
what? Wait.
Yes, I've sent you 2 patients.
Yeah, 2 patients in
Yes.
Paulina. Just wait. That's opening. Okay.
They were divided into 2 emails because
Yeah,
English was
I have both email on my desktop, but doesn't.
I may try to share my screen if you want to.
Yeah, try to share your screen. Yeah.
Okay, I just need to open. Can you see my screen?
Not yet.
Yes, I see, Paulina. Ja widzę.
Okay.
You should have seen my Word file.
Okay.
I can try to share it once again.
Yeah.
Okay, so I will stop sharing. And now? Do you see the screen and the presentation?
I see the screen. All you see the screen?
Yes, I see the first page of the presentation.
Okay. So, do you want to speak about your patient? How lucky you are, Paulina.
The first patient is patient orthognathic.
These are the four Frankies patient of Langlade. Michael Langlade is an orthodontic from France. Call this kind of patient the patient of the ticket to send this patient to a different orthodontist. That's the cost of the bus to take the bus and go to the next one.
Yeah. Yeah, they're quite difficult patient. Thankfully, to me, the patient number 1 agreed for the maxillofacial surgery.
Yeah.
So this makes him a little bit more easier because without the surgery, it will be very, very difficult to have correct occlusion and nice aesthetics. So thank God he said yes for the surgery.
Perfect.
And I think it's quite important information because when we are preparing him for the surgery, the treatment will be a little bit different because we need to concentrate on the compensation of the malocclusion. And this is the patient with the skeletal class 2 with the anterior rotation. And he has a severe protrusion of the upper incisor and even more severe protrusion of the lower incisors. I will show you the photographs. So maybe on this one, we can see that the shape of the arch is highly deviated. It's flattened in the anterior region. And the canine and the premolars are very much flared toward the palatal side. it's not so much visible on the photographs. I think it's more visible on the plaster models. Unfortunately, I left them at the office, so I cannot.
I don't see the slides, Paulina. Something is wrong.
Okay, so something
Because it's white.
have frozen.
Yeah. Now it's okay.
Okay, is everything okay now?
I see it. Yeah, raro.
Yes,
I see too.
Okay.
Yes.
It's not so much visible on the photographs, but the lower incisors are so much proclined that we even think about having the extraction of one. Okay, so shall we? Oh no, I think it's Kinga sending the message.
Okay, wait.
Oh no, Kamil.
Nie widzimy teraz prezentacji, Paulinko.
Okay, because the Kamil message showed up. Can you see the screen now?
No.
Not yet.
No, I don't see anything.
And now?
Okay.
Yeah, perfect.
Okay.
Okay, so back to the lower incisors, we are even considering with the surgeon the extraction of one lower incisor. But for now, we decided to try to align the teeth and postpone the decision about the extraction of one of the lower incisors.
Yeah, that's very important because when you extract an incisors before doing surgery, in this case, the extraction of the incisors could be too much, and that's correct. I think that's correct to start without extraction. Yeah.
Yes.
And,
start with just the uprighting of the upper teeth, a little bit of stripping and distalizing as much as we can. And if it will be not enough, then we will extract one incisor, but we will try without the extraction. So with the upper arch, my plan was to put the high torque on the central incisors because they are quite retruded. Then the standard torque on the laterals, especially this one.
Yeah.
Maybe high torque on this one, but I would start with the standard and if necessary, rebond for the higher torque. And in canines and premolars on both sides, higher torque because of the proclination. And especially if we move the models into the surgical bite, then we see that they are even more retruded. So we need to flare them towards buccal sides a bit. And with the lower arch, if there will be no extraction, then I would go for the low torque.
Mm-hmm.
And if we eventually decide to extract one of the incisor, I think I would switch to the standard torque.
Perfect. Oh, yeah.
And with the posterior areas, also high torque, so that they will correlate with the upper and will not have the Brody bite.
Mm-hmm. Yeah, I love also the prescription of high torque that you put on the upper premolars, because in this case we need to change completely the torque value of these premolars on the upper arch if we want to permit to the surgeon to move the mandible. And so that's correct. And so you see Paulina put upper canine and premolars high torque. It means that we need more torque and we need brackets with higher value of torque on premolars or hard torque with the pliers or with the coil. how do you think to do it, Paulina, about the premolars on the high torque on the premolars, on the upper premolars?
I will start with the high torque brackets, but I think maybe at some point of the treatment also the extra torque bending will be needed.
Yeah, and so, but which kind of brackets are you using?
I am not using Damon brackets.
Yeah, but
I am using mostly the 3M brackets. So in this patient, I would use the bracket with 0 torque. For the premolars, and for the canines also either 0 or +7.
Perfect. Yeah, yeah. Doesn't matter which kind of brackets, just the value that is important. To try to use different value to start having the torque effect. Yeah, that's correct, Paulina. And a surgical case. There is someone who is asking something about the surgical case, because surgical case sometimes makes afraid our treatment as orthodontist. But as a matter of fact, surgical case, the big problem of the surgical case is the surgeon. Yes. Is to have the right feeling with the surgeon. Last time I've been in Siena, we saw a case, orthodontic surgery orthodontic case in which the surgeon probably made a mistake during the operation and didn't explain to the patient that it could happen, but just say to the patient, there is no mistake, just go to the orthodontist and make the treatment. And that's very important. If you are doing, and sometimes we need to do some surgical orthodontic case, have the right management of your colleague and your colleague of the orthodontist. And patient has to know everything very, very well. What Paulina also explained us today was about the extraction of one lower incisors on the and to redefine with the surgery if to extract or not. And also in that it seems a good way with your surgeon, Paulina. Yeah.
And also with you ask about the premolar and the canine region, and we also decided in this patient to use corticotomies in this area to allow the flaring movements a bit easier and faster. Yeah. So and even I saw the patient yesterday. And really the effect of the corticotomies, he's 1.5 months after corticotomies. We already activated the appliance yesterday it was 3rd time, and really the effect is I'm really impressed with the effect. Yeah. So despite being on quite small arch wires, the effect is really nice.
In this patient, there is probably a good cooperation also of the patient due to the fact that there is a real bad malocclusion. The problem with the patient sometimes that when they have a small amount of malocclusion, try to give not enough cooperation. This patient is a patient in which Paulina just offer to him the right solution. This is a surgical orthodontic case. It's not an orthodontic case. And the problem is that there are some surgical cases that are still treated as just orthodontic case. And that could be a big problem. Brava, Paulina, brava. Next patient, Paulina.
The second patient, This is a younger girl. She's around 15 years of age.
Okay.
Do you see the screen or it?
Yeah.
Okay. So this is the girl. She is also having the class 2 relation, but her biggest problem for now is that we are lacking space for one canine and the second the right canine, and the left canine erupted, but it erupted a little bit ectopically. It's more to the vestibular side than in the arch, and we can see we have some protrusion of the upper incisors, and the space is not enough. And in this patient, we decided to distalize upper arch and to recreate the space for the canine by distalization, and then to correct class 2 also with further distalization. And the distalization was done on the distal slider. So she has 2 mini implants on the palatal side, and I've put the distal slider. And with the brackets and the torque of the brackets, so on the upper arch, with the incisors, I decided to put the standard bracket. Because they are flared, but they are not flared so much. And I think for the smile aesthetics, this a little bit excessive flaring is not bad. With the canine that is already here, I put a lower torque canine, because a lower torque bracket, so that we will put it a little bit more to the arch.
Are not afraid to
incline it too much. Now I'm thinking about
incline it and about the roots.
Yeah,
of course, there are pictures, and we can't appreciate if the roots are in a vestibular position too or not. From the picture, it seems a little bit vestibular, but of course you have to check with the finger if there is too much vestibularization of the roots or not.
Yeah, I even have the CBCT of the patient because of the mini implant.
Okay.
So I will even check it on the CBCT.
Yeah.
And in the posterior region, we can see that they are also inclined to the palate, so the higher torque values. And in the lower arch, lower, the incisors are retruded. So I think about the high or standard torque with the canines low torque, and with the buccal segment standard torque.
Okay. Yeah. I agree with the incisors, and low torque on the cuspid, on the canine.
Yes.
Are not afraid to move the roots with the low torque too on the other side of the cuspid of this one.
Okay, I'll check it.
Yeah. Just the canine as the lower canine as this problem that usually we think at the low torque, and we have to imagine what's happened to the roots. If you have the combine, of course you see them as perfectly. And yeah, of course, with a distalization with mini screw, it's not a problem of anchorage on the frontal teeth. Yeah. So it's necessary to choose, as Paulina explained us, the right torque depending from the smile line and the flaring effect. Yeah.
Yeah, and I also decided to put the higher torque on the bicuspids, because with the distalization, usually the teeth goes a little bit into crossbite, so that to not to have such an effect due to distalization. I also thought that the higher torque will be more beneficial for this patient.
Yeah, yeah, perfect.
Yes,
Perfect.
and with the incisors, I think I put the photograph with the smile and the profile. So if we retrude too much the incisors, I was afraid that the upper lip will collapse and
Yeah.
she will not have a good profile. And we can see that now she's showing incisors quite nicely, so that maybe it will not be perfectly on the cephalometric tracing, but I think with the profile and the smile, it will be very good to remain them a little bit flared.
Brava, 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 Paulina.
Thank you.
Brava.
Those were my two patients.
Yeah, that's fine. Brava. Which is your argument on the thesis, Paulina?
On my thesis?
Yeah.
But you're asking about the topic of the thesis, or?
No. Which is the topic? Yeah, the topic of the thesis.
The topic of our thesis is the obstructive sleep apnea.
Okay.
And my part is the diagnostical part, the symptoms and diagnosis of pediatric sleep apnea.
Okay, perfect. Brava.
Thank you.
Brava, Paulina. Okay, is Inga with us? She has one patient or not? No? I don't see her. She's Kinga, sorry, Kinga. 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 Do you listen me?
Yeah. Maybe she went to have lunch.
Yeah, probably. Okay, see you at 2 o'clock.
2 or 3? 2.
The direct time was 2 o'clock.
2
okay?
o'clock.
Okay,
Yeah.
sorry, my
Yes.
mistake.
Yeah.
Yes.
Okay, see you at 2
Yes.
o'clock.
Yeah.
Okay.
See you. Bye.
Bye.
Bon appétit.
Buon appetito.